Okay, let's move to the next section. The next section's topic is Fluciclovine pad for prostate cancer, applications and advice. Let's welcome this section's chairperson, Director Lin Lifan.
Okay, good morning, everyone. It is my great honor to introduce Dr. David Schuster. David Schuster is the Director of Division of Nuclear Medicine and Molecular Imaging of Emory University. So if you remember, last year we also have Dr. Schuster with us. He gave us a very excellent talk about the fluciclovine PET. So the new amino acid PET tracer for prostate cancer. So with his presentation last year, we can see we know that the fluciclovine seems very promising and also clinical potential. But unfortunately, because of the government regulation, we still cannot use it so far in Taiwan. But I have good news for our audience. In this July, our TFDA has approved this drug for clinical use. So I think in the near future, we will soon have the opportunity to use this new PET tracer. So today, we very honored to invite Dr. David Schuster to come here to give us another talk. Today, we will more focus on the clinical application. For example, the comparison between the fluciclovine PET and the conventional image. Of course, I believe that Dr. Schuster will share us his very valuable experience in the image interpretation, right?
Yes.
So let's welcome Dr. Schuster, please. Dr. Schuster, please.
Thank you very much. The title of this talk is Fluciclovine PET for Prostate Cancer, Applications and Advice. These are my disclaimers. And once again, thank you very much for inviting me. Let's start with a case. This patient has a PSA of 4.9 post-EBRT, brachytherapy, and prior androgen deprivation. Had a negative multiparametric MR and CT for extraprostatic disease. In fact, they were noted to be unchanged from prior exams. With fluciclovine imaging, we see uptake in a 7 by 4 millimeter aortic cava lymph node. It's quite small. It has intense uptake. And I'm going to blow it up. It has a fatty hilum, and this was malignant on laparoscopic biopsy. Fluciclovine is a non-natural amino acid PET radiotracer, otherwise known as FACBC, or the trade name of Agjumin. Amino acid transport is upregulated in many cancers, including prostate cancer. The whole body biodistribution is different than that of FDG, though the effective dose equivalent is similar to FDG PET. The most intense physiologic uptake is in the liver and pancreas. There's moderate to mild activity in the salivary glands, pituitary, adrenals, and muscle, and there's more marrow heterogeneity than we see with FDG. There's mild to no activity in the brain and, most importantly, the bladder, though one can get an early excretion variant in a minority of patients. There's variable activity in the esophagus, stomach, bowel, and adrenals. Locate Phase 3 was a multi-center intention to treat trial in the US, enrolling over 200 recurrent prostate cancer patients. The median PSA of this trial was 1. Detection rate varied with PSA level, from a high detection rate with a high PSA to a detection rate of approximately 30 to 50% with a PSA of less than 1. Most importantly, there was nearly a 60% change in management post-scan. The Empire 1 trial, or the Emory Molecular Prostate Imaging for Radiotherapy Enhancement Trial, was conducted and recently completed at Emory, in which we took patients who had prostatectomy and biochemical recurrence. They were then stratified and randomized into either Arm A, radiotherapy or salvage therapy planning based on conventional imaging, most of this was MR, or Arm B, in which treatment decisions were also modified by the addition of fluciclovine PET. The study fully accrued with 162 patients. The primary aim was to compare 3-year PSA-free survival between both arms. Now, if we look at the positivity rate, and fluciclovine is in orange, fluciclovine did better than conventional imaging, both on a whole body and a regional basis. And radiotherapy was changed in 35% of cases. And these are just some examples of fluciclovine imaging with positive lymph nodes. But many studies have shown that imaging causes a change in management. The big question that hasn't been answered by most studies for any imaging is the change in management correct? Does it change outcomes? And for the first time, we can say for prostate cancer, the use of fluciclovine imaging does change outcomes. And here we have data that was presented at the ASTRO 2020 meeting in October. The fluciclovine arm is in red, and the conventional imaging arm is in purple. And this is failure-free survival. So both at 3 years and 4 years, there was improved failure-free survival if you used fluciclovine compared with conventional imaging. And that's 75 to 63%, getting even bigger at 4 years, about 75 versus 50%. So fluciclovine does make a definite difference in this patient population if you use it for salvage planning. Fluciclovine is FDA approved in the United States for biochemical recurrence. And now it is also Taiwan FDA approved as of July 2020 for the same indication. Fluciclovine and choline are included in the NCCN guidelines for recurrent prostate cancer. Now, a word about PSMA and fluciclovine. There have been 2 recent papers published in which patients got both fluciclovine and PSMA scanning, and they were performed at UCLA and also the University of Graz in Austria. We're not going to get into the details because we don't have time, but we can conclude a few things. First of all, fluciclovine and PSMA are significantly better than conventional imaging. Fluciclovine has an advantage in local detection. This is important to guide salvage therapy. There is low urinary excretion compared with most PSMA radiotracers currently, and you can inject an image on the table. You don't have the 1-hour uptake phase that you have with PSMA. But PSMA radiotracers do appear more sensitive than fluciclovine and choline for extraprostatic detection with similar high specificity. This is also important to guide salvage therapy. The differences are greatest at low PSA levels and in bone. Now, I think that eventually fluciclovine will kind of fade and PSMA will become more dominant. But I think there will still be a place for fluciclovine, especially for PSMA negative or equivocal disease. So certainly there's a skill for fluciclovine interpretation as with FDG. And fluciclovine, I think, is more technically demanding in acquisition than FDG. There's fast kinetics and you must acquire it correctly. But standard training and interpretive criteria are available. And once your technologists get used to acquiring it and you get used to reading it, then it becomes second nature. PSMA is not yet FDA approved or widely available in the US or Taiwan. But as I've noted, with time, PSMA will likely subsume fluciclovine, especially once low urinary excretion PSMA is approved, which is a little further off, but it's being researched now. But I think that fluciclovine will be still valuable for some of these scenarios. Now, this leads us to the Empire 2 trial, which is ongoing at Emory, in which we're taking the same cohort of patients who are post-radical prostatectomy. They have biochemical recurrence. They're being stratified, then randomized into either arm A, in which they are being salvage planning based on the now standard of care fluciclovine, or arm B, in which we're doing salvage planning based on gallium PSMA, We're going to be looking at 2-year and beyond PSA-free survival, as well as some other interesting endpoints. And the study is now over 1/3 accrued. It's going very rapidly. This is just an example of a node positive on fluciclovine and PSMA from this trial. Now we're going to get into the more practical aspects. First, the clinical imaging protocol. There is some very good detailed documents available, like the ACR ACNM practice parameters and the joint ENM SNMMI procedure guidelines. I'm going to refer you to those, but I'm going to emphasize a couple points. First, we think it's important to have the patient refrain from voiding immediately before going on the table, getting injected and scanning, because a relatively distended bladder may mitigate the occasional early fluciclovine accretion. So if you can, have the patient not void for about 15 to 30 minutes before the scan. Of course, patient comfort in the scanner is more important. We then inject 10 millicuries, start your stopwatch, and then you have plenty of time to get the CT. Then at 3 to 5, target 4 minutes on the stopwatch. The PET is started from the bottom up. And again, once your techs get used to doing it this way, it becomes like a ballet. There's a full reader training program available through the Society of Nuclear Medicine Clinical Trials Network. You can Google Agjuman reader training, just have to register and you could take the training for free. Now, just as with any other imaging, you should be familiar with incidental uptake invariants, such as this female patient from a different trial who were looking at breast cancer, which lit up. Now, though amino acid transport PET is less prone to inflammatory uptake compared to FDG, we see it much less frequently and much less intensity, but it can happen. So this is a patient with prostatitis that lit up with fluciclovine, and BPH can be a confounder. Also, like with sestimibie, fluciclovine can get a little sticky in the vein on the side of the injection, but with PET-CT, that's easy to read around. The general interpretation criteria is predominantly qualitative. And one should be familiar with the patterns of spread of any cancer that you read. So the general guidance for prostate cancer is inside out. That's how the prostate cancer spreads. So you want to err on the side of specificity, especially when you're first reading. MAR at L3, assuming L3 is normal, is a more highly specific comparator. With increasing experience allowing for partial volume effects and your equipment, you can call additional areas of uptake suspicious. You could ratchet down your threshold with smaller lesions. So let's deal with post-prostatectomy first. Most commonly, we get a recurrence at the vesicourethral anastomosis. Sagittal images are especially useful to differentiate your physiologic periurethral activity, which I'm going to show you, from abnormal activity. Next come the lateral surgical margins or seminal vesical beds, the retrovesicular region, and other less common locations like the urethra, bladder wall, or rectum. So for post-prostatectomy, the suggested interpretation criteria are focal uptake equal to or greater than bone marrow is likely malignant. No focal uptake is likely benign, and focal uptake between blood pool and bone marrow, then you might say it's that in-between place, and you can call it equivocal or follow-up as recommended, or it doesn't meet the threshold for malignancy. Now, if you have a very small lesion, less than a centimeter, then you may want to ratchet down your threshold. And you can say, well, if significantly greater than blood pool, but if it's maybe getting close to marrow but not quite reaching it, you also may want to call it suspicious or malignant. And MR is very helpful here. So this is a patient who's post-prostatectomy with a PSA of 0.29. And recurrent prostate cancer is suspected. Here we can see the fine periurethral activity, but then there's this little hump that does not belong at the vesicourethral anastomosis. It's greater than marrow, and this is a recurrence. Now, this is a patient with negative prostate bed. First of all, it is normal to see a little mild symmetric activity in the bladder wall. As we come down, there's no activity in the lateral resection margins, And if we look at our sagittal images here, we have kind of the periurethral. It could appear as single or dual. You could often see rectum, but there's no abnormal uptake at the vesicourethral anastomosis. This patient has a PSA of 0.16 post-prostatectomy, and this is a subtle case, but here we can see our periurethral activity, but there's a little hump here that does not belong. Notice there's really no activity in the bladder, so this is not radiotracer, and this is just anterior, maybe in the bladder wall at the vesicourethral anastomosis. So I think one could be comfortable calling this positive, even though it's not quite at marrow, but it's significantly greater than blood pool. The patient achieved nadir after salvage radiotherapy. Now, you could sometimes have these strange recurrence patterns. This is a patient who has a PSA of 10.05. Notice how thick the urethral activity is. Again, it's not radiotracer because there's no radiotracer in the bladder. So we suspected something was going on. This is biopsy-proven recurrence invading the urethra, and the patient is doing well now on androgen deprivation. Moving on to non-prostatectomy. Relapse tends to occur at the treated primary site, also external to brachytherapy seat coverage by our experience. In our original NIH-funded trial, specificity in the prostate was lower, about 40%, with a positive predictive value of 75%. So this is where you can get a little bit of more false positives, probably due to BPH and or inflammation. So here you want to use a higher threshold. Diffuse focal or multifocal uptake greater than bone marrow is considered likely malignant. But this is very important because these consensus panel 2 criteria will maximize your sensitivity. We've since done some research showing that the higher your threshold, for example, twice that of marrow, the higher your specificity. You can maximize your specificity with only a modest loss of sensitivity. So it just depends where you want to be on that sensitivity specificity continuum. No focal uptake is likely benign, and if it's diffuse focal or multifocal uptake between blood pool and bone marrow, then follow-up is recommended. It's kind of like in that in-between place. So here's a patient with a non-prostatectomy treatment, and you can see this heterogeneous intense activity, and that was positive, biopsy proven malignant. Now this patient has very bland, homogeneous activity, and it's really not greater than marrow. Admittedly, it might be a little borderline, but it's very kind of boring and biopsy proven benign. Moving on to lymph nodes. First, it's important to divide the lymph nodes into those greater than or less than a centimeter in maximal dimension. Now, if for your report, you're going to use short axis or bidimensional, that's the convention. But for the purpose of this visual analysis, we're just going to use maximum dimension, and the lymph node has to be in a typical site of recurrence. So if it's uptake equal to or greater than bone marrow, it's likely malignant. Less than or equal to blood pool is likely benign, and if it's that in-between place, we would say it's equivocal or follow-up is recommended. Now, if the uptake is in a node in a typical site of recurrence that's less than a centimeter maximal dimension, you could bring down your threshold, and you could say something is positive if maybe it's significantly greater than blood pool, and maybe it's approaching marrow, though not quite there yet. So you can call that likely malignant, or if it's hotter, of course. Uptake less than blood pool is likely benign, and if it's in that in-between blood place, maybe it's just a little hotter than blood pool, then you could say follow-up is recommended. Now, it's not only comparison to marrow. There's other factors that should be factored in when you're looking at lymph nodes, such as location. You have a higher suspicion for typical areas of recurrence. It's common to have mild to moderate symmetric uptake in inguinal, distal external iliac, axillary, and hilar nodes. Shape. Round nodes are more suspicious than curvilinear nodes. And grouping. Depending on the category, a group of nodes in a typical location is more suspicious than a solitary node. It's like criminals sometimes run together in gangs. It's the same idea. And necrosis. A necrotic node may not have much radiotracer uptake. just like we see with FDG. So here we have a patient with a rising PSA of 2.31 post-EBRT and brachytherapy. MR was called negative for extraprostatic disease. Here we see intense uptake in a sub-centimeter right common iliac and obturator lymph node, and these were malignant on laparoscopic dissection. This is the opposite. This is a patient with a rising PSA post-therapy, and there's a 1 centimeter node here I'm showing you. There were some other nodes nearby. MR called these definitively positive for lymph node involvement because they had restricted diffusion. But if we notice with fluciclovine, there's hardly any uptake at all. A lot less than bone marrow. So we think it should have been hotter for its size. We thought it's likely malignant. This triggered a biopsy, and this was confirmed benign. Now, these less than 5 millimeter retroperitoneal nodes are significantly greater than blood pool, and they're at least approaching, if not as much as marrow. And notice how they're rising up in the retroperitoneum. These are typical for prostate cancer recurrence. So you want to call something like this an intense lymph node, which is greater than 1 centimeter here. In the right iliac bifurcation region. You don't want to call positive these mild to moderate symmetric inguinal distal external iliac or maybe periacetabular nodes. Now, this is an unusual case. Patients post-EBRT and brachytherapy had a PSA of 2.14. Notice there's uptake in the lateral bladder wall and a left external iliac lymph node, very intense. There's also uptake in sub-centimeter bilateral inguinal nodes. These are very small, and there's no inflammation nearby. There's no graft nearby. So this is much hotter than you would expect to see. Could be bladder cancer, but a biopsy showed positive for prostate cancer in the inguinal node. Moving on to bone. Because there's more marrow heterogeneity, you want to see your uptake on the MIP images. The PET-only images can also help you. Lytic or silent lesions are typically more intense than sclerotic lesions, and a bone abnormality visualized on CT only, like an indolent sclerotic dense lesion, may still represent a metastasis. Most sclerotic lesions with fluciclovine will light up, but some that are slow growing may not. In that case, you want to get MR, sodium fluoride PET, or bone scan, but don't stop at planar bone scan. Make sure you at least get a SPECT CT. This patient is post-radical prostatectomy, PSA of 1.1. We could see a focal uptake on the MIP image near the end plate. It corresponds to a subtle sclerosis. And actually, MR was initially negative, but then they repeated the MR and it subsequently showed a metastasis. We've seen cases where a MET can resemble a Schmorl's node and there's uptake within it. So it's important to integrate both the PET and the CT information. But this patient here had a slowly growing sclerotic lesion. There's absolutely no fluciclovine activity. This was also MET. Sometimes we have a case like this where we have multiple scleroses on CT and it's hard to tell what's happening. This patient had a PSA of 10.5 and actually the bone scan was a planar bone scan and MR were negative. So are these bone islands or are they metastasis? Well, fluciclovine can really help because with fluciclovine, that pubic ramus lesion lit up, the others did not. And we managed to get a CT scan from over 3 years before, and all these were stable except this was a new sclerosis. So this was the MET, and you could direct biopsy to that area. Finally, liver. Because you have normal physiologic activity in the liver with fluciclovine, you may not see metastasis very well. Sometimes windowing widely can help you. So you could have a metastasis to the liver and it could appear less activity than the liver itself. So it could appear photopenic. If you think that's happening, get a CT or an MR. This patient had metastatic castrate-resistant prostate cancer. Notice there's a lot of mediastinal and abdominal nodes, a left supraclavicular node, quite hot. Patient was placed on chemotherapy. Everything disappeared or shrunk down, like we see this left supraclavicular node. But look, between the pre and post chemo, you could even see a new hypodensity in the liver at the dome on CT, but it appears relatively photopenic compared to the liver. We biopsied this, and this is a prostate metastasis. So I thank you very much for your attention.
Hi, Dr. Schuster. Thank you for your great talk. With your, I think especially for your awesome experience sharing about the image interpretation of physical PET. So now I think we have 7 minutes for discussion. Are there
Okay.
any problem or comments about Dr. Schuster's presentation? Okay, then let me make a start. Dr. Schuster, I have a question about the CT quality. Because
Okay.
when I see like the page 26, you have used the sagittal view to check the anastomosis between the urethra and the prostate, the bladder
Right.
bed. Yeah,
Right.
so do you use the diagnosis CT or attenuation quality CT for the general fluciclovine PET CT? Because when we use the attenuation quality CT, when it goes to the mounting plane, for example, the sagittal, sometimes the quality is really awful. So how do you overcome this problem? Thank you.
Sure. So this is generally what we do for all PET CT. We use in between. Okay, so we use about maybe 80 to 100 average MAS. So not as high as you would use for a diagnostic or an optimized CT, but not really low. So we want to be able to see the structures. So we kind of use a lower threshold, a lower dose CT, but I would say in between one of those very low dose blurry CTs and the really, CT that you would use when you give contrast. So we take the middle path.
Like just adjustable CT
Yeah,
quality.
right.
Okay,
We
yeah,
kind of
that's
go in
great.
the middle, in the middle. Yeah,
Yeah, so I think that the new equipment of PET-CT can do that. So that can be for our
right,
audience reference in the future. So,
right.
and is there any other questions? Okay, then I have the time to ask another question. I am really curious. For example, you have talked about the bone mats and the squamous node. So I'm curious about that. If the inflammation or degenerative changes on the spine, could that cause false positive fluciclovine uptake?
You hardly see that. So like osteophytes, you rarely see osteophytes or facet activity positive with fluciclovine. Occasionally you do, and then it's obvious. There is a pattern, which I didn't have time to show, where sometimes we get red marrow regeneration in the pelvis or the proximal femurs. And sometimes you can get what looks like a solitary kind of linear lesion. So you don't want to overcall that. If you think that's happening and you see kind of a solitary lesion, I would say get an MR that, to really correlate it or do a biopsy. Because sometimes that's just red marrow and sometimes it's actual metastasis. And I actually, in the longer talks, I actually show one of each. But as far as degenerative disease itself, it's much less common than you see with FDG or even with PSMA, now that I'm using PSMA. So.
Thank you for your complete answer. So, is there any other questions? Okay, well, with Dr. Schuster's sharing, we can see that because there is no bladder activity of the fluciclovine in most cases, so that it really helps us to detect the
Yeah.
recurrence lesion in the prostate. So that's looking forward for this new tracer can be go to the clinical daily practice. I have a news that maybe come in next February. Yeah, so because of the time is up, so I would like to close this session here. So let's thank you, Dr. Schuster. Thank you.
Thank
Thank you.
you.
Thank you.